Welcome to the series uncovering the latest 2025 American Thyroid Association management guidelines for patients with differentiated thyroid cancer. This is Endo in a Bite, where I break down complex concepts into bite-sized pieces that you can actually remember. Today, we will be discussing recommendation 21 to 30. Let's begin. Starting with recommendation 21. Surgeons must have a clear discussion of surgical risks with patients undergoing thyroid surgery. That includes a frank explanation of the potential for nerve injury as well as parathyroid injury. These are not optional points. They should be explicitly covered during the consent process. Equally important is communication with anesthesia and the broader care team. Preoperative findings, whether imaging, functional, or clinical, need to be clearly and consistently shared across all providers involved in the case. Recommendation 22 extends this discussion into preoperative voice assessment. Every thyroid surgery patient requires evaluation of voice prior to surgery. That begins with history and physical examination, specifically documenting any changes in vocal quality. In patients with dysphonia, with prior neck surgery, or with high-risk thyroid cancer, laryngeal examination is mandatory. These steps are central to protecting the recurrent laryngeal nerve and ensuring operative safety. That brings us to recommendation 23, which focuses on nerve management intraoperatively. The standard of care is visual identification of the recurrent laryngeal nerve during thyroidectomy. Neurophysiological monitoring can be a valuable adjunct, reducing the risk of nerve injury. In select malignancy cases, monitoring of the external branch of the superior laryngeal nerve may also improve postoperative voice outcomes. Another key practice point is stimulating either the recurrent laryngeal nerve or the vagus nerve after completing a lobectomy to confirm nerve integrity and prevent bilateral nerve injury. Recommendation 24 shifts to parathyroid preservation. Every effort should be made to preserve parathyroid glands and their vascular supply during thyroidectomy. When glands are inadvertently devascularized or removed, autotransplantation should be performed. Postoperatively, patients undergoing total thyroidectomy or central lymph nodes removal should receive calcium and vitamin D supplementation. Now, recommendation 25 addresses drains. Routine drainage of the thyroidectomy bed is not recommended. In fact, data show that it prolongs hospitalization and increases the risk of infection, with no measurable benefit in reducing hematoma formation. Drains should therefore be avoided in almost all cases, with very rare exceptions. Recommendation 26 returns us to postoperative voice. Every patient requires postoperative voice assessment. When abnormal voice is noted, a formal laryngeal exam is essential. Surgeons also bear the responsibility of communicating intraoperative findings to the care team. And in cases where recurrent laryngeal nerve injury is identified, early referral to speech and voice specialists is strongly recommended. Recommendation 27 shifts focus to pathology reporting. Pathology reports must extend beyond AJCC staging alone. They should specifically document vascular invasion, nodal involvement, and extranodal extension. The pathologist should also identify aggressive, histologic subtypes of differentiated thyroid carcinoma, as well as favorable subtypes, and should note any familial syndrome-associated variants. That brings us to recommendation 28, which highlights the role of the 2025 risk stratification system. This updated system integrates pathology, nodal status, imaging, and biochemical markers such as thyroglobulin and thyroglobulin antibody levels. The goal is to provide a more accurate estimate of both recurrence and survival risk in differentiated thyroid carcinoma. While molecular profiling is not yet considered routine, it may in some cases add nuance and refinement to risk assessment. Recommendation 29 takes the next step with the American Thyroid Association response criteria. These criteria categorize outcomes and recurrence risk following surgery. They are most useful when applied in conjunction with the risk of recurrence framework, as together they guide the intensity of therapy and the frequency and type of follow-up monitoring. Finally, recommendation 30 focuses on post-operative thyroglobulin measurement. For patients who have undergone total thyroidectomy, serum thyroglobulin should be checked 6 to 12 weeks post-operatively. This can be assessed either while on thyroid hormone therapy or following TSH stimulation. The results play a central role in guiding subsequent management. For those who have undergone lobectomy, at least a single thyroglobulin measurement is warranted to ensure that there is no unexpected biochemical evidence of disease progression. Let me say this all again in the form of one-liners. Surgeons should review surgical risks, including nerve and parathyroid injury, and communicate findings with the care team. All thyroid surgery patients need voice assessment, and laryngeal exam is required with dysphonia, prior surgery, or high-risk cancer. Visual recurrent laryngeal nerve identification is standard. Monitoring recurrent laryngeal nerve and external branch of the superior laryngeal nerve and vagal stimulation may reduce injury and improve outcomes. Preserve parathyroid glands or autotransplant if removed. Give calcium vitamin D after total thyroidectomy or removal of central lymph nodes. Routine drainage after thyroidectomy is not recommended due to longer stay, infection risk, and no hematoma benefit. Postoperative voice should be assessed, findings shared, and recurrent laryngeal nerve injury referred to voice specialists. Pathology should report AJCC, features plus vascular invasion, nodal status, extranodal spread, subtypes, and familial associations. Use the 2025 risk stratification system to guide recurrence risk. Molecular profiling is not routine. ATA response criteria should be applied post-surgery to guide therapy intensity and monitoring. Measure serum thyroglobulin 6 to 12 weeks post-thyroidectomy or lobectomy to guide management and detect unexpected elevation. That's it for today's bite-sized episode. Missed a detail? No stress. I've taken the notes for you. Just head over to easyendoprep.com to sign up for the weekly newsletter, and pearls will be delivered straight to your inbox. The PDF contains additional details not included in the podcast. Remember, stay consistent, and we'll work through all 84 recommendations together, one bite at a time.